Today we're going to be talking about coronary physiology. Alan, so tell me, you've been using physiology for many years. How have you integrated the use of intracoronary physiology in your general workflow in the cath lab?
Well, I think by now, obviously, this is something that is not brand new anymore. As you point out, we had this technology available for, 20 plus years, right? But I think how it has evolved over the last few years is kind of interesting, right? From the original FFR measurements, which were a bit of a production, if you will, to now the much more streamlined resting measurements, IFR being the leader, as you know. But obviously now every company has a resting index, right? And to make those measurements actually takes almost no time, right? It's just as long as it takes you to pass a wire and basically are ready to record. So it's very, very simple and straightforward. And I think at the end of the day, to the benefit of the patients, right? Because as opposed to always discussing, should you do FFR, should you do a resting index, really the discussion is do any type of physiology you want to do because you're going to have better outcomes by using it.
Yeah, absolutely. So the conversation has really moved forward, hasn't it?
I think
It's
so.
no longer a debate over which index. It's more about when we choose cases to do it and how we're using it to guide our intervention. So in what kind of case would you typically perform a physiological measurement like IFR or IFR Co-registration?
Well, I think you actually made a very good point, right? Because I don't think everybody has evolved from just doing a spot measurement, which is what physiology was initially designed to do. Remember, when it came out, and still I think how it's used in most of the cases, is to just make a decision whether or not you want to treat something, right? You're not sure, the lesion might not be significant angiographically, you want to have a more objective assessment of ischemia, so you pass a wire, you make a measurement, and you determine, whether or not you want to treat something. But what you mentioned, I think, is a bit more sophisticated and more nuanced, right? Where you say, well, can we also use physiology to make decisions how we're going to treat?
Right.
That's a little bit different, and that's almost like imaging, right? It's when you do an IVUS or OCT pullback, you're getting basically that pullback information. Now you can do the same by doing this IFR pullback, as you say, and even co-registering it to the angiogram. And so now you have an angiogram, obviously old style, if you will, but with an overlay of a physiology map, and you can really figure out how to do a PCI if you so.
Yeah, so there's been a real movement and evolution away from vessel level ischemia. So, and I think the original aspects of physiology was really good in that respect. We could identify the vessel, but now we're moving to a lesion level and identifying where in the vessel the most ischemia is coming from, and how you're going to perform your intervention. So talk me through your use of a technology like IFR Co-registration and how you would use it on a day-to-day basis.
Well, since I have been using it now, I guess on a routine basis, I must really say it is amazing how it transformed my practice.
Okay.
Because I really, not that I don't see the lesions on the angiogram, but it helps me in a few different ways. So I basically use it routinely when I pass the wire, because why wouldn't you do it? It takes you 10 seconds to do it, doesn't cost anything extra, there's no additional drugs you have to give, it's very simple, so why wouldn't you use it when you have it? And it can do a few things for you, right? It can confirm that the lesion you thought on the angiogram was in fact the culprit lesion, is the culprit lesion, and you can go ahead with confidence and treat it. Or it can show you, oh, there's another lesion, in addition or instead of the one you thought, right? And that's very eye-opening. Once you have done some of those cases, you're like, wow, I never thought this would be a significant lesion. Or what can happen also is that it completely transforms what you think is going on. And instead of having a focal lesion, which angiographically you might have thought this is the case, you actually have diffuse disease. In which case your treatment might be completely different, maybe bypass surgery or medical therapy as opposed to PCI.
So you're making a real change in your treatment decisions and your thought processes on how to manage an individual case.
Right.
So you actually ran a really important study that opened our eyes to how we perform intervention. It's called the DEFINE PCI study. And in that study, you talked about missing lesions. And I would say as interventionists, we're looking at the angiogram, we're very focused on looking at disease that we can see. And yet your study showed something slightly different. Can you talk me through that?
Yeah, so DEFINE PCI was actually a study looking predominantly at the PCI results.
Yeah.
So we looked at lesions that were significant physiologically as an entry point, but then the idea was to do PCI as of standard of care. Basically, based on the angiogram, imaging was allowed if the operator so chose, right? And then what we said, when the operator thought they had a good result, they basically were done with the case. We asked them to do a blinded IFR assessment and IFR pullback.
Right.
So we can determine what is the rate of residual ischemia in those cases where you thought you did a good job.
Okay.
And then more importantly, define where it's coming from. Right. Is it that the stent wasn't optimized that was placed? Is it that they missed a lesion? Is it that there's diffuse disease and the stent's not going to make a difference? And so what we found was that in a quarter of cases, 24%, IFR was still at this ischemic level of 0.89 or less.
Right.
So that's higher than I thought it would be, first of all. Yeah. And then what we found is that the vast majority of cases where this happened, 80%, actually were missed focal lesions.
Wow.
So diffuse disease was predominant in 20%, which is not a small number.
Yeah.
But in 80%, potentially, the PCI result could have been optimized with that information.
So this is absolutely fascinating. So an interventionalist has recruited a patient into the study, they performed the angioplasty to the best of their ability, achieved what they feel is an optimal result, and yet in a quarter of the patients, the vessel was still ischemic.
Right.
And in 80% of those cases, there was still focal disease that had been missed.
Correct.
So this means that perhaps we're not understanding the angiogram very well, even though these are expert operators, and this is showing us that the physiology is demonstrating something that we hadn't appreciated or seen.
Well, I think there's a couple other lessons here, right? The first lesson is that this is not even average angioplasty.
Yeah.
This is better than average angioplasty because remember, everybody had a physiology assessment in the beginning.
Right.
Which is also, not, I mean, how often does it happen?
Yeah.
10 to 20% on average in the US or in the UK. So this was 100% physiology guided, if you will. So only those lesions were in fact addressed that were significant by physiology.
Okay.
And even in those cases, we only have 75% success, if you will, 25% still have significant ischemia.
Right.
So that's a pretty interesting finding.
Well, it's an eye-opening finding, isn't it? Because it really shows us that we've got to up our game if we're going to be able to help our patients.
Well, it also shows that we need to transform how we use physiology, right? Because it's not a spot measurement, it's what we discussed before, using that pullback to identify how to best treat the vessel.
That's really eye-opening stuff, and I think it's something that we should all be integrating into our practice. So this is absolutely fascinating. So an interventionalist has recruited a patient into the study, they performed the angioplasty to the best of their ability, achieved what they feel is an optimal result, and yet in a quarter of the patients, the vessel was still ischemic.
Right.
And in 80% of those cases, there was still focal disease that had been missed.
Correct.
So this means that perhaps we're not understanding the angiogram very well, even though these are expert operators, and this is showing us that the physiology is demonstrating something that we hadn't appreciated or seen.
Well, I think there's a couple other lessons here, right? The first lesson is that this is not even average angioplasty.
Yeah.
This is better than average angioplasty because remember, everybody had a physiology assessment in the beginning.
Right.
Which is also, not, I mean, how often does it happen? 10 to 20% on average in the US or in the UK. So this was 100% physiology guided, if you will. So only those lesions were in fact addressed that were significant by physiology.
Okay.
And even in those cases, we only have 75% success, if you will, 25% still have significant ischemia.
Right.
So that's a pretty interesting finding.
Well, it's an eye-opening finding, isn't it? Because it really shows us that we've got to up our game if we're going to be able to help our patients.
Well, it also shows that we need to transform how we use physiology, right? Because it's not a spot measurement, it's what we discussed before, using that pullback to identify how to best treat the vessel.
That's really eye-opening stuff, and I think it's something that we should all be integrating into our practice. Since you've started using IFR Co-registration, how have you felt when you're making the measurements? How easy is it to make them, and how easy is it to interpret the findings on the screen?
It's pretty straightforward. I think the beauty of it is that it does not require a pullback device. So it actually follows, you have to do fluoroscopy while you do it. So let's say it takes 10 or 15 seconds while you do the pullback, so you have to stay on fluoro for that duration.
Okay.
But basically the computer understands how the wire moves because you have the radio-opaque part, which obviously is a defined distance, if you will. And so it can use that information to co-register it to the angiogram.
Right.
And so based on that, you can also make length measurements, right? So you can also see, okay, if I put a stent that is, I don't know, 28 millimeters, I would basically cover this amount of territory, of physiology territory, if you will,
Right.
and would recover my pressure to X number. So it's actually a very, very, neat way of predicting what's going to happen before you go in and do the angioplasty.
Okay, so you're using it to interrogate the vessel, you're then pulling the wire back to map out the disease, and then you're actually making measurements to know the length of the disease, as well as what the potential gain would be from a physiological point of view.
Right.
Yeah,
Right.
It's absolutely fantastic.
And obviously you have been involved, I think, in one of the major studies looking at the before and after. Because then the question is, well, isn't there crosstalk between the lesions?
That's right.
And if so, how much? We know with FFR that's a problem, right?
Yeah, so the complexity of this is really quite tricky to be able to work out on the fly. And when you're performing a pullback assessment under maximal hyperemia with an adenosine infusion, I think we find that we end up making multiple runs. We have to give adenosine many times,
Right.
and you have to repeat the measurement every time you place a stent. Because what you predicted will not be what you actually gain. But what we found with IFR is that seems to remove all of that doubt, and you can plan in upfront and in advance before you've actually performed your stenting.
Right. And in your study, right, the error rate from predicting to afterwards measured
It was
was
very small. So
1%, a little over 1%, right?
So our study was particularly small, very complex disease. What we found in our clinical experience has been using it in more routine cases, the accuracy is very, very good. Naturally, you have to have very good technique, and there's always pitfalls that you can fall into. As long as you're using the appropriate approach, I think you get good results.
Right.
Yeah. So, Alan, tell me, how about the use of imaging and with IFR Co-registration? Many people tell me, they say, oh, well, I'd like to use an IVIS or an OCT run to plan my angioplasty. Does the use of IFR prevent you from doing so, or how do you marry that information together?
Well, it's a good question. I'm fortunate at St. Francis that we don't have a lot of restrictions in terms of finances.
Right.
So we are a very, very large imaging center. As you may know, we looked at our numbers last year. We had 84% of patients receiving PCI at St. Francis had imaging.
Wow.
So from our perspective, obviously the two are not
They're not mutually exclusive.
they're not exclusive. In fact, they work together very well.
Right.
So because you're looking at different things, with physiology, you want to know the first step, right? Do you need to treat or not? Should you treat or not, right? And then the second step is, if you do, how to do it, which is what the pullback does. But then the imaging gives you another layer, I think, which is important if you're really considering doing precision PCI, where you say, okay, let me find a landing zone that has maybe less than 30% plaque burden, right? Let me find a landing zone where the plaque is not lipid, because that will dissect for sure, or not calcium, right? Which is the best landing zone? What is the size? I think what is very common in stenting these days is that people undersize the stents based on the angiogram. We have a lot of data.
Yeah.
And all of the events are associated with minimal stent area. So if we can maximize that minimal stent area, we should reduce the event rate. And in fact, many IVIS trials have shown exactly that.
Yeah.
I think if you want to really, use or do the best you can, you probably will have to do imaging on top of physiology as well.
That's right. So using the physiology to guide where you do your intervention, and then the IVIS to help guide landing zones.
Right.
Because, if you've still got to stick to your...
And sizing, right?
Yeah,
Sizing is key.
and-
If you start doing imaging on a regular basis, what you find also is that you will have to do a lot more lesion preparation than you thought, based on the angiogram.
Yes.
So our rate of atherectomy actually is much, much higher because of that, because we identify calcium to a much greater degree. And we know that if you have calcified vessels, you can't expand the stent properly, and stent under expansion is a very strong predictor for adverse events.
So, Alan, can you think of a case where using the IFR Co-registration system really altered your plan for the patient?
Many cases, right? Many cases. I mean, if you do this on a more or less routine basis, as I said, you will be really surprised how frequently it changes your management, right? Because when you plan a case based on the angiogram, I mean, you will put a stent, which is the most obvious lesion, but you might miss a lesion, you might miss diffuse disease. You don't fully understand that, I think, the length of disease just based on the angiogram. So all of these things are certainly aided by doing a co-reg and really understanding, the physiologic map, if you will, of the vessel.
So it's really moving angioplasty into a whole new era where we're guiding intervention with a combination of imaging and physiology together to improve the outcomes of our patients.
And the truth is that, even though I might be practicing like that right now based on the data we have, you could play devil's advocate and say, look, we don't have the data at this point to definitively say it's a better strategy. We need to do a randomized trial, and we actually are planning exactly that.
Yeah, so we're looking forward to hearing of the next DEFINE set of
Me
studies.
too.
Yeah. So looking forward to hearing the results of that in due course, Alan. Well, thank you so much for joining us today, and
Thank you.
I'm sure the audience would have found that very helpful.